Comments from the members?
I think that's a great idea because at least in the border rack area, we do a lot of things and we like to share those things. And by the same token, learn from all the other racks too. Because I mean, we're taking care of trauma patients. Trauma patients are trauma patient regardless of the location. So I think that's a great idea.
I agree. I think it's a great idea. Our rack director is right there, Matthew Baker. So Matthew can help us speak to it.
What I want to make sure I'm not doing is creating more work for the RAC directors who also will be at the RAC chairs meeting. So that's the reason I want to hear what y'all have to say, and I'd like to hear from what the audience says.
Matthew, do you have any comments on reporting to the trauma committee? What's up here on the screen? Does that mean you want to or you do not want to? No.
On schedule. Wanda?
Certainly don't mind thinking about for the work that we do. I think we'll just have to get together and talk about structure because we will have to give them very short
5 minutes alone.
work and we'll figure out.
The reason I think that's important is we do, I'm the world's worst at getting the minutes done, but I will get the minutes done, so they're available. So there are a lot of people when we go to these legislative meetings who ask us, what are some of the things that you've done? What are some of your accomplishments? What are some of your barriers? And the barriers are very different based on the RAC and the geographic population and the size. So I think it'd be nice if we had some information or we knew where there was a great RAC doing this, we could point them and realign them to connect with those specific RACs. So let's talk about some of the other RAC chairs, RAC ED directors. Christine, what do you think?
Wherever you want to, where I will provide.
Actually, Christine provided the report almost instantly. Tell them what you did with your PI process. I thought that was really cool with the geriatric patients.
Oh, because I had to send that to you already. So we noticed that we were having some patients over the age of 64 being involved in low speed FDCs. And so they were kind of falling out of our realm. We noticed that we had several, for about a 3-month period, or correct me if I'm wrong, we had like 4 deaths. They ended up being 3 or 4 deaths.
Well, they were low mechanism elderly that were not required to go to a trauma center.
Right, that
and
would be criteria.
right
So
for our regional destination protocols.
So we changed, after we saw there was a death, we decided to change our regional PI to take a look at all potential mechanisms of injury if they were over the age of 64. You can imagine it made everybody really upset because there was a lot of people we were going to look at. But when we looked at it, we found that that if there was even a low mechanism, they're over the age of 64, they needed to go to a trauma center because you may not know what their comorbidities are. They may be talking and speaking at the scene, and then within an hour, they do real bad.
Yeah,
Sorry.
one of them had a major pelvis that looked fine to begin with, and then he decompensated at the non-trauma center. By the time we got him, he was behind the 8 ball. And then the other one had a high C-spine injury that it just from his age, probably, a minor mechanism, had him, piff himself. But they both decompensated, and there were several of them that seemed to happen over, a short period of time. And so we got together with our physician advisory group and our hospital care management group and the EMS, our pre-hospital groups, and just kind of decided to put an age criteria a little higher up on the list of patients that needed to go to a trauma center.
Good. And your outcome was improved in care, right?
Yes, it has been. Our level 4s actually are transferring out anybody over the age of 64 immediately, like they were a level 1 trauma.
Right.
So we
And
just,
so, Christine, do you consider yourself a large RAC?
no, by our discussions at our December meeting, we are a small RAC.
Well, I think that's important because everybody talks about, well, the big RACs can do stuff, but these other RACs are doing a lot of really good stuff, and that's the point of trying to bring this information forward. So,
Can I use that again?
So Danny, what do you think? Okay. Carolyn, Terry, I know y'all are highly involved in your RACs. So we're going to move forward with this? Yes? Okay. Committee, yes?
Yes.
All right. Okay, Irene is, her goal was to look at the trauma registrars and again to create templates for all facilities to look at job descriptions, org charts, organizational structure, as well as the education and development, and how to progress from a new registrar to a registrar that completes the CSTR, the certification, and how to help that process, as well as when you should go through the AAAM injury scoring classes. So Irene is working with the trauma registrars to do this. She's not here. And then Miss Edwards, I know you're here. So Miss Edwards was asked to, her and Miss McNabb, to look at the electronic medical record and to develop a best practice model or a white paper on how to implement the the electronic medical record in the trauma center, and not just in the trauma flow sheet, but all the processes that we use in the hospital to gather data for the trauma patient population.
So the draft paper has been completed. What it addresses is from a easy interoperability for the provider, from transitioning from the trauma resus base through the OR inpatient settings and off to rehab, where the focus is on, one, making it easy for the provider to enter it, making it information that's relevant to the provider, not just for billing reasons, but also discusses information that matches the national standard. It addresses the ongoing evaluation and updates necessary to the electronic medical record. Many products, many institutions have encountered resistance that here we finished it, here it is, it's staying this way forever and a day, and it's not ever going to change and evolve. But trying to make it a focus and an important aspect, and to recognize that we are an evolving discipline and that it needs to evolve just as our national standards do and our focuses within our institution, so that we can incorporate that PI issues into our documentation, but not just so we can check a box. So it addresses all of that from a very high level, looking at it as, and making sure that your trauma surgeons, your trauma registrars, and your trauma program managers are directly involved with your building team, whatever that may be. So the draft has been forwarded on to the chair. I can very easily forward it to you all for your opinion. And
so is that the final draft?
That's the draft that Wendy and I are done with.
Okay, so yeah, I'll forward it.
We are done with it after this past year of looking at the research, going into the lit reviews and all of that.
So the two electronic medical systems that were used were Epic and Cerner. So
that's what we used as an example.
Right.
So the paper itself is not specific to any one product, not specific to any one type of facility. It's big overarching goals. This is what it should be. This is what it should be. And then as an example, we have used Cerner and we have used Epic to illustrate the points that we were trying to make.
Okay, so we'll put this on the agenda, and I'll send the paper for y'all to look at, and I'll post it on the website so everybody in the audience can see it. Thank you, Courtney. Lori Vinson, the pediatric trauma coding, specifically looking at abuse issues.
Well, I guess with the new information about validation of data, we have to reconsider some of what we're looking at. But one of the things we wanted to look at, based on, more and more data is coming in. So we did have an issue with some centers' data not crossing over, and I know that Chris and his team has been working through that as more centers' data is crossing over. But you will find a discrepancy sometime in the volume of child abuse patients that we know exist, as opposed to when you pull the E-codes for that information. Sometimes people are using things like assault as opposed to going into a child abuse E-code. So we wanted to look at that. Some racks had no patients with the child abuse code at all, which, knowing what I know, probably can't be the case. So we're going to continue to look at that data. I've got a report. I've been working with Erin. She's been great from the state office for the registry, and continue as more data comes in to look at it, but then provide education out to those areas to say, we need to just look at this and be sure that we're choosing the right ones. With that, we're going to want to look at some other things that are specific to pediatrics, but obviously we're going to have to work with Chris' group and the validation piece as well. So we'll keep you posted on as we work through that particular item.
And again, there's a lot of people that question or have questions about access to pediatric education, pediatric trauma, so you want to comment on that?
As far as,
They want to know if they have access to PowerPoints or somebody like you coming to their RAC to provide that?
yeah, so I think all of the pediatric centers are very open to coming out and providing education. Child abuse recognition is one of the big topics that has come up recently. But with that being said, talking about the E-codes, just got invited to go to the Waco area. I'll be doing that in June. And then just got something from the Panhandle as well, so looking at July. But there's a lot of others at the Children's Hospital, so anybody can freely contact me, and I will help you contact somebody that can help you do that.
And I just also want to say that the Society of Trauma Nurses has that electronic library. I think every RAC has access to that. It's on the TTAF website as well as the state website. So if you don't have access to education, you can always go there because it's built for you to be able to get CE Youth. Carla, Christy, any information on update on alcohol? This goes back to Jane with the trauma rules, but we've already heard about the trauma rules, right? This was one of the items that was put on the agenda at the last committee for discussion. This is specifically hospitals who are saying that they want to be designated. They don't want to be full designated trauma centers, but they want to be designated. So the example that I have is that they can receive orthopedic trauma patients because they have an orthopedic service there. So they're not really interested in being trauma center for the whole patient population, only they want to be a trauma center so that somebody can transfer them specific patient populations for operative intervention. So wanted to put this on the agenda because I got a call, 3 different calls, 3 different teams, 3 different RACs that they wanted to do this. It's interesting, almost all of the requests were specifically around orthopedic surgeons. And so I asked Jane about it. So Jane, I'll just let you comment on that.
Well, now we're talking about niche hospital. Okay. Our rules say that we designate the facility, and you have to have all of the things that go along with that facility to only accept a certain type of patient that would not be in agreement or compliance with our existing rules or statute.
One of the hospitals that called me, they wanted me to come out and be a consultant for them. I'll just share this with the group. And so my comment to them was, even if you became a level 4 facility, you cannot accept patients. And in the city where you live, where there's a level 1 and a level 2 trauma center, it's going to be unrealistic for you to think you're even going to get patients if you go for a level 3 to be transferred into your facility. So anyway, just wanted to make sure everybody had the same information.
Well, my thought on that too is say you got a middle-sized town hospital, if you will, that has a full complement of orthopedic surgeons. There's more to being trauma designated than just being able to fix a broken bone. Right. There's the trauma QI piece, there's a prevention, there's the outreach, and I don't. If all they're going to do is say they got an orthopedic surgeon that can fix
That's not providing service.
Then I don't think it should apply. If they're going to include all that other stuff, then maybe we discuss it.
We had that conversation. But I think the only reason I want to bring it here is because if I'm getting those phone calls, somebody else might be getting those phone calls, and there might be that discussion at the administrative level in different hospitals. So I want everybody to hear the same information. So this is the feedback part. So Dr. Stewart's not here. I can tell you through the ACS, and I'll ask Dr. Winchell to comment on this, as well as Dr. Gandhi, because I know they're involved in the process as well. There's obviously a big focus on the PI, rolling out the new ACS standards and the new Orange Book. So anybody in the audience doesn't know that goes through the ACS does not know that there's a new Orange Book that's out there that's available. You can buy the book. The rules go into effect July the 1st. So if you are going to be reviewed by the American College of Surgeons between now and June the 30th, it will be by the Green Book. If you're going to be reviewed by the American College of Surgeons from July the 1st, 2015 forward, it will be by the Orange Book, whether it's a consultation or an actual verification review. Everybody got that? If you've got questions about that, you need to get on the phone and talk to Molly. Dr. Winchell?
That's right, and the book itself is actually available for download on the college website, as is a compendium of changes as to what's changed between the two volumes, most of which are evolutionary rather than revolutionary. I think the biggest piece involves trying to codify PI and be substantially more definitive and prescriptive in how PI is being done than the book used to be. And I'd say the second big piece was to try and level the clinical standards between level 1 and level 2 centers. Since patients are often transferred similarly between level 1 and level 2 standards, the standards for trauma surgeon availability, anesthesia availability, and a number of other subspecialties have been pretty much equalized across the board. I think those are the biggest changes.
There's one other change, and that's in the pre-hospital participation at level 1 trauma centers. The pre-hospital participation in the PI and level 1 trauma centers has been substantially elevated. And so now the full circle has come through in terms of the pre-hospital really being part of a robust PI in a level 1 trauma center. And so I think that's a very important piece that's been added. In terms of the niche hospitals wanting to do trauma, I think either you are a trauma center or you're not. Personal opinion, as a RAC chair, as a trauma medical director, I feel the same way. Even an isolated orthopedic injury, many of us have already seen, is not just an isolated orthopedic injury, especially in those patients who are 55 years of age and older. It takes a lot more than just an orthopedic surgeon to take care of that patient and that patient population. Thank you.
Any other comments from the members about the change in the gold book, orange book? Anybody in the audience have any questions about the orange book? I would imagine you've all read it, right? Those of you it's pertinent to you. So EMS, Mr. Ramos?
Well, I guess we already touched on several topics. Chrissy's talked about compliance validation and EMS data. The other part that hasn't been discussed was that Chris, I don't know if he's still in the room, that if we sent, and I don't know if it's true for trauma, I'm assuming it's going to be the same thing, that if they request EMS reports, they have to be very, very concise as to the forms that they use so they can actually tell you if the registry actually has those data elements, and that their report will be back in 10 business days. That's one of the things that was mentioned at EMS.
Any questions from the members? RAC chairs, Dr. Gandhi?
Nothing in specific.
Okay. Courtney or Kathy, the Texas Trauma Coordinators Forum update?
So the Texas Trauma Coordinators Forum met on Tuesday. They participated in the Capitol activities coordinated by TTAF, participated in that. In May, on Monday, May 10th, we'll offer the Trauma Designation Education course, which meets the requirement for education for trauma program managers. On Tuesday will be our general meeting that will be an all-day activity. 2 hours of continuing education will be offered during that meeting, and moving forward with some of the new focuses with our 2014 goals that we decided at the strategic plan in January. Questions?
And the TIPS course will be in August,
The
correct?
TIPS course, yes, TTAF's Injury Prevention Symposium will be offered on Monday, August 16th, the Monday before TTAF, which meets on Tuesday, and then the GETAC. Yes.
Courtney, I have a question.
Yes.
I know that trauma education is very hard to come by aside from topic, course, and the trauma conferences. Do you guys make available through webinars like those 2 hours that you guys?
We do not make available through the webinars. It's as a benefit of the membership and attendance to the TTCF meetings. every meeting, there's 2 hours of continuing education. One focuses on the clinical education, one is more towards the administrative purposes of running a trauma program.
Thank you.
Any other questions? Perfect, thank you.
Sally Snow here. You want to give an update from ENA?
I really don't have anything to report, sorry.
Okay. Pediatric, Lori?
So the Pediatric Committee of GETAC didn't meet this time, but just another update for pediatrics. I talked about this at EMSC. I talked about it at the pediatric portion of TTAF. But recently in the Dallas-Fort Worth area, there was a surge in a pediatric ICU bed capacity issue. So through that region, we worked with our RAC, which is RAC-E, North Central Texas Trauma RAC, to develop a mechanism within M Systems where we could get updates on pediatric ICU beds in other regions. So through our RAC, we were able to work with Waco as well as Houston to get those updates on a routine basis. So what it showed us is that it's a great resource and capability to provide that information, obviously, for other events and other patient populations. It would be a great tool to use as well, but I just wanted to acknowledge RAC-E and Anne-Marie and Rick Antonese for working with us to help us resolve that issue and get some data in real time.
Thank you. Any questions for Lori? Anything from the level 4s? Kristen? I don't have anything either. Level 3s, Lisa's not here. Anybody from a level 3? Kathy?
Through the feedback through the TTCF from the level 3s and also through the surveyors, there's a concern from the level 3s that they are not receiving feedback from the facilities that they're transferring into. Either they're not receiving feedback at all or they're receiving feedback in a non-timely manner. So we did meet about that, and that will go right into the level 2 and Miss Lori.
I'm a participant on the level 1 and 2 committee with TTCF. It's led by Joelle and Terry Valentino. We did discuss Tuesday, I guess it was, the issue that the level 3s and 4s are not getting timely, sometimes any feedback or for sure timely feedback. And then around the table we kind of talked about, what does your feedback letter look like, the one that you sent? And there was a lot of variation. Some is, just very global in nature and doesn't give you very much information. And then there was some very detailed follow-ups. So our plan at this point in time, and we got an email today, we're all going to take a look at our feedback forms and try to come up with a minimum set of data elements that each one of us, you can go above and beyond those data elements, but things like length of stay, ISS score, diagnoses, procedures, a core set of things that would be beneficial for the level 3s and 4s to get back in a timely manner, but we're going to work on that process.
Are you guys going to work on defining what timely manner is? Okay.
And another thing we did discuss was that if it's a PI issue, they get feedback very quickly from the higher facilities. It's just that getting the ISS and the length of stay and all those kind of things back.
Okay. Jory, one more thing. Based on your comment, we also talked about the different ways in which each one of us gets those letters back to the 3s and 4s. And a lot of us do it through the RAC meetings. I take envelopes with me to my RAC hospital care management group because that's where all my coordinators are. Some mail them, some do different things, and so in coming up with what is timely definition, also can we establish a mechanism that is fairly constant.
It's kind of the same topic, but not. But do you guys provide feedback to your EMS services as well? Mm-hmm. And is there a time frame or a format, or how do you do that?
I don't have a format or a time frame. We're beginning to do that, and it's pretty much verbal at this point. Mm-hmm. But I don't have a form yet. We're developing that. What about you guys? Or the audience?
So we have a stand.
We actually developed this year at EMS all one of the years our hospital follow-up forms. That was a big concern about EMS. We won't get a lot of follow-up. For any EMS colleagues in the room, knew what EMS was actually looking for. We send follow-up letters on all our level 1 and level 2 trauma activation. We're trying to do every single EMS patient that came in the door before it did. So, if there's any EMS folks in there that are looking for particular things, they can be real helpful. We may want to try to into the level 1 and 2 because that's a real important piece.
And we're polling ours, as from y'all's discussion, Conrad was polling our EMS providers and asking what they want to know. You complain about you want feedback, or what feedback do you want specifically? I haven't heard back over the call, but they're new to have back up in the mark.
I think those are very good points, because I think the hospital could identify what we think is important that they may want to hear about, but sometimes there's some variability. So we have some standard things that we give feedback, but then also on a case-by-case basis, they contact us onto those cases they feel are important, and we get that to them back in a very timely manner, so.
So we have developed a similar process as Terry for all the level 1 and 2 activations. We have standardized format that goes to EMS and to the referring facility, but also we're fortunate in Austin to be part of the health data exchange with EMS. So essentially we are eliminating the need for EMS follow-up because it's immediate. And so that's something that our RAC is moving towards, and so that's been a great thing. But we also polled EMS and the data points that they would like to see follow-up on, and they really wanted everything. And so we're asking to be just a little more specific, and they wanted follow-up on every single transport. And I don't think they quite understood the length of time that it takes, and and the time frame of the length of stay of the patient, and then follow-up. So through the health data exchange, I think that solves all of those issues, and so we're very fortunate to
Yes,
have that
you
in
are.
place.
We researched after we found out you guys were doing that, and I think our region has chosen to do it through the regional registry because our EMS used their funds to start our regional registry.
Right.
So we're going through that route, but I really like
It's
the health data
fantastic.
exchange.
It really has. I mean, it's eliminated a whole process for our trauma department. So.
Anything else for the 2s and 3s? So from the level 1s, the biggest issue is that most of you know that we did, through TTAF, agree to support the Texas TQIP. So that means any hospital that's currently participating in TQIP would be involved in that. Currently there's 14 hospitals. So where we're at right now is that the TQIP organization just hired a new contract person, so they're actually working on the contract from their end. So hopefully at the May meeting there will actually be a meeting to talk about that. And then one of the things that I wanted to ask the group is, I know this will impact every level 1 and every level 2, is the new taxonomy for PI. Some people have already moved to that, some people haven't. But in the May meeting we will have a topic course on Wednesday. The question is, would you like to have like a work session on how to use this new taxonomy that we can schedule that's separate, like in the afternoon or something like that?
Yes.
It certainly would be open to all the 3s and the 4s as well, but the bottom line is, now by May there should be some consensus on that particular subject. So, so the committee members say yes?
Yes.
How about the audience? Is there an interest in that? Okay. So we'll make that happen. And then injury prevention, Carla, did you go?
Just the course that she mentioned, Courtney mentioned.
I know Courtney's on. Shelley, any information from the injury prevention committee we should know about?
I think many of you probably heard us talk about the components for hospital-based injury programs that the Injury Prevention Committee has been working on in conjunction with RACS, TTAF, TTCF, and those were approved by the Big GETAC Council at the November meeting. They're available online on the Injury Prevention GETAC website right now. We can also, I think several of the RACs have printed up copies for their particular RACs. We are going to be, because evaluation is, we didn't want to just create a document and then just say, here, go forth and use it. So we have an evaluation planned for that, and that will start in the May RAC and GETAC meetings where it's about a 15 or so question survey, just asking if they've seen if you've seen the document, if you've started to make changes as a result of it, and things like that. The survey, we're probably going to do a combination of pen and paper as well as online. We'll distribute the survey in May, probably again sometime August, November meeting, and then again in a year. And our intent is to track to see if the document is making any difference in terms of using data, using evidence-based programs, partnering with collaborators and groups like that. So that's the big thing that we talked about.
Okay. The other thing from to just bring up is we did have the American Trauma Society here on Wednesday morning, and they did the Trauma Survivors Network. So I obviously helped bring that here, so I would ask somebody else if they want to comment on whether or not they felt it was beneficial or not.
I had the pleasure of attending that, and I thought it was awesome. The American College of Surgeons were there, there were representatives from there, and we had 2 trauma survivors that was there, and it was truly, truly awesome. And it's something that is, if you belong to the American Trauma Society, you can get the handbooks and get it all developed. Otherwise, there are other ways to do it. But it was something that I thought would be beneficial that any level trauma center could do, and it was really, really good. Any feedback from those? Because I see faces in the audience that was there. What did y'all think?
Beneficial? Good. Okay. So I know Dinah's still at the Capitol. Brenda, any update from TTAF?
Good afternoon. I'm Brenda Putz with TTAF. Thank you for giving me the opportunity to speak for just a moment. I'd like to first introduce our new staff member, Courtney DeBauer. She's in the back there. She's our new legislative coordinator, and she works closely with Dinah. She comes to us with a long experience. She's really old in the political arena, so we're excited to have Courtney on board. Dinah, as Joy said, is very, very busy at the Capitol. There's a Senate Finance Committee hearing today, and I think that's where Dr. Eastridge and Darrell Pyle are as well. We are really geared up and working hard during this session. We had Trauma Day at the Capitol. It was very successful. We were excited to see we gave out lifesavers, and we had little stickers that said, I'm a lifesaver or I'm a life saved. And as we went around to the different representatives and Senate offices, we found them in every office. So the Texas trauma coordinators came out in numbers, as well as the RACs, and we were very excited to see the participation. It was a very positive atmosphere, and we had a great day. We are continuing to support the DRP. We have the bill was filed by Sylvester Turner calling for the allocation of all of the funds in the DRP and red light running. And so we're supporting that. And of course, the RAC initiative for additional funding is being supported. We're very busy with that. We have classes coming up. The hospital data management course is February 26th and 27th. The EMS data management course is coming up in May. We're supporting a trauma conference in July in Amarillo and a stroke STEMI conference in April in Amarillo as well. I think that's it. Can I answer any questions for anybody? Thank you.
Chris, you've already addressed a lot of issues. You have anything else you want to share?
Just a couple more things. Brenda just talked about the hospital data management course. DSHS has a hospital representative from each RAC that will be attending on that hospital data management course. So we're able to move on from the terminology of champion to just a hospital representative for this training. Also, it's tentatively scheduled for June 11th and 12th for the AIS training. DSHS will be reimbursing the cost for 22 hospital representatives, 1 representative from the 49 level 3 trauma facilities. I understand that we have more level 3 now, but when the time the grant was written, we only had 49, and then 1 additional DSHS staff member to attend that training. So it's tentatively scheduled for June 11th and 12th.
Congratulations. It's time for public comment. Anybody from the audience have anything they want to make us aware of? Go up to the mic.
While he's coming, I wanted to put one thing down because I know we're out of town. One of the things that I think we need to work on after this legislative session is to have our insurance chair look at the possibility of increasing the medical liability on car crashes to $250,000. That would probably pay for over 90% of our patients that are coming in, and so alleviate some of the financial issues we have in our institutions.
And Jory, I still want to talk about how we can obtain better compliance with getting EMS run sheets in a timely manner, like when the patient's dropped off.
Okay.
Hi, my name is Anil Sinha. I'm a trauma medical director for a level 3 trauma center in Lake Jackson. I wanted to just echo Dr. Gandhi's comment regarding the specialty hospitals that are trying to take care, cherry picking in my opinion, certain patient population knowing that they will be well insured. And I think they're going to just take them DRG as much as they can, and when the patient has a complication that they need other treatment, then they will try to transfer it to a higher level, having sucked out the essence of the care. So that was just to reinforce what I feel is very important.
Thank you. Any other public comments? Quiet group. Anybody on the committee have anything they want to bring up for the next committee?
With regard to the run sheet, can we, I know we've talked about it here, but I mean, should one of us be going to the EMS committee and talking to them and getting it on their agenda? I mean, basically what we're left with is, from what the state has said, is that we can call and report them, but none of us really want to do that. We just want to be compliant with the information, obtaining the information to help take care of the patient.
Alex is our EMS representative. Does it count that we started late because the last committee ran late?
They did talk about a project that I can't recall which rack.
About had a project.
Data repository where they would place it. However, that doesn't really get the problem off the
it doesn't meet the standard.
Doesn't meet the standard. So yes, we can have it as in the trauma registry to extract if that works across the state or even across the country, because it's not unique to Texas. But it's a fact of dropping off the pertinent information. And how the Texas code is written, they're just required to drop off information, and that's how they're saying, well, I'm dropping that information. However, the complete run sheet really makes an impact on how well we can treat a patient as soon as they arrive to the trauma bay, or even in the OR, or even in the ICU a couple of hours later. So it does impact. I mean, we're dealing with a national problem, not just here in Texas. And if we can't enforce and ultimately take the responsibility that we're taking care of patients, not just to meet a regulation, and that's what we try to echo in our region, that yes, there's regulations, however, our first duty is to the patient.
Maybe we can have a meeting with the EMS committee and talk about that.
Yes. Jane, you're at EMS. They talked about the new surveys they're going out to do about if they're meeting all the requirements and not just Senate delay, but everything. Do you have a PI program? Might this be something that we might could put on that where they, they show that they are providing the run sheets in a timely fashion, because it's in the rule, and it is one of the rules, but I don't remember if it's under M or not, so that's one of the things they were talking about is.
Or that they have to get a letter from the hospitals that they serve saying they're in compliance with that.
We can look at all different kinds of ways to do it, Kristen.
I just know that particular survey process is supposed to be on their May agenda to talk, to get more information about what we're doing, because it was brought up in just public comment today, so they service it.
The question is, at any time of survey, they ask, are you submitting? The system's gotten better. The system's gotten better where we can start cross-matching the data. So I know there's a lot of frustration out there. I just say hang in there. It's getting better, and I think you'll see a lot. You won't have this discussion as
Okay, so we have that as an agenda item. Any other agenda items for the next committee? It sounds like a lot. Simple issues, right? So if not, any announcements? Any announcements from the state? Anybody else? Then I'll consider this meeting adjourned. Thank you very much.